Hi, I am Dr. Rahi Victory, and welcome to Fertility Fact or Fiction. I am your host, and I am a Canadian and American board certified reproductive endocrinology and infertility specialist. And this show is all about helping you on your journey to a easier, more successful, more efficient, and hopefully less costly fertility journey and successful outcome. So tonight we have a good topic. It's one we've done before. About a year ago, actually, we have a video on it, but this one's a little bit different in what they did and how they did it. So I wanted to review this new study with you guys, and interesting what they claim at the end of it. So I'm actually going to say I disagree with the authors in this one, but we'll go through it together and I'll explain. Hopefully you guys have all been doing well, watching our new posts. We're trying to be a bit more active on Instagram, although I don't think it goes anywhere. Instagram is impossible to grow as far as I'm concerned. So if you know people that want to follow us, please make sure that they do. Everybody loved that post. What's up?
So there was a question that was on one of your YouTube videos.
Okay.
And they're in Australia.
Uh-huh.
So they asked if you could answer their question before doing the talk. Just this one question because
sure, fire away.
Just because they're in Australia. They said,
okay.
But they're waiting for it.
Okay, they're waiting in Australia.
Yeah.
Fire. We're gonna answer Australia. What is it?
And they asked it on last week's show once it went on YouTube.
Oh, okay.
So like they're waiting.
Okay, sure. What is it?
Hi from Australia.
Hi from Australia. Okay.
What are your thoughts on aminosentites? I'm 42 and
amniocentesis.
Amniocentesis.
Okay.
Correct, sir.
Yeah.
I'm 42.
Yeah.
PGTA was a viable option considering my age group and poor prognosis. We've done the test and one normal embryo was transferred, and now after one trimester screening at 18 weeks, the risk came back as one of 46 for chromosomal abnormalities.
Oh, interesting.
The doc pushed us to do amino, waiting for the results. Hope they will be good. Just interested how this is done in your clinic in Canada. Do you prefer non-invasive tests or amino testing, since it's the only test that provides definitive answers? Kim.
Well, thank you for watching all the way from Australia, Kim. And the answer to that is actually quite simple. There is no way you need an amnio. And that would probably be the last step, and only if there was a controversial answer. So if you've done PGTA has a less than 1% error rate if it's done by an appropriate center. So you're already in really good standing. 1 in 46 from your early first trimester screening result is more than anything being driven by your age. And at that age, almost everybody screens positive. So because the age factor is so high as part of the equation once you're over 40. So that's very significant in terms of why you're screening positive. Following that, the next step would not be an amnio, especially in an IVF pregnancy where the amnio does carry a 1 per 200 risk of miscarriage. The actual answer would be to do a non-invasive prenatal test where they can actually pick up fetal DNA. That has a 1 in 10,000 error rate. And as a result of that, there's no reason to proceed with an amnio if your NIPT would be negative. So that would be our protocol here. It would be your PGT, which is fine. You're negative. We wouldn't even encourage you to do NIPT or EFTS because you can rest assured the baby is normal. If you did, we would go straight to NIPT because here in Ontario, it's covered for women that are over 40. So we would go straight to NIPT. But even if you did do EFTS first, the early first trimester screen, we would never do the amnio unless we absolutely had to. So if your PGT was negative, meaning you were okay, and you got a positive EFTS and then you got a negative NIPT, we would not do anything. If you got a positive NIPT, okay, now I would be concerned that you have a negative PGT, but you've got a positive NIPT. Which one of these two is more accurate? You could maybe argue that it's reasonable to do an amnio at that point. But besides that situation, there's no reason for you to do an amnio. So sorry to jump in front of the rest of the paper, but that was an important one for us to answer from Australia. Now everybody from Australia is going to ask us to answer.
No, it was one. It was one.
We need to set up screen share. We didn't do that.
No worries.
I will hook you up. So tonight's topic, very interesting, like I was saying earlier, about whether or not frozen embryo transfer is safer for the fetal outcome than fresh embryo transfer is, and vice versa. And so we're going to go over all of the various findings in regards to this, and talk about what these authors found. And this is a very, very large study. So the last time we reviewed this, it was actually a meta-analysis and systematic review where they pulled together all the different studies and pooled them and then said, this is what they found. This is actually a single study from the UK where they analyzed over 200,000 live births in 151,561 women. And they had about 132,000 singletons. They actually had 33,698 twins and 5,723 singleton siblings, where there was one born and then they had another one born later on. And they did comparisons between fresh and frozen for the siblings as well to see what it showed. So let's have a look at the study. Are we on share right now?
Mm-hmm.
So it's called the Comparison of Perinatal Outcomes After Fresh or Frozen Embryo Transfer, Separate Analyses of Singleton, Twin, and Sibling Live Births from a linked National In Vitro Fertilization Registry. This is coming from Aberdeen University, and one of the authors, Bhattacharya, is very well known because that was one of the authors that compared doing nothing for unexplained fertility, Clomid for unexplained fertility, or Clomid and IUI for unexplained fertility, and then showing which one of these was best. So it was a very interesting study, and that author is quite well known because of that. Okay, so let's go to the meat of it. So number one is right here. So this is basically how they conducted the study. A total of 770,702 cycles that were done. They excluded almost 600,000 because there were no births, which is horrible in terms of the success rates. I mean, I find that insane that they had so many cycles and yet so many of them didn't result in a positive outcome. Why, some people would ask? Well, probably a large part of it is that in the UK it's very structured and very cookie cutter medicine. We have loads of patients that contact us from the UK, and I'm actually in the process of setting up a UK office because of the fact that they do terribly out there in terms of listening to patients and collaborating with patients. They did have 1,452 triplets, and they actually had 12 quadruplets, which is not normal, but anyways. So they eliminated some where there were either no embryo transfers or more than 3 embryo transfers. There were some where there was a fresh and a frozen cycle. I'm not even sure what that means. Maybe they thawed frozen embryos and transferred them with the fresh. That's the only way I could think of that. And several other exclusions. So they ended up at the end of it all with 24,028 singletons that had a frozen embryo transfer. So a huge number. 108,651 that had a fresh embryo transfer. There were consecutive siblings in several of them. So there were large numbers there as well. And you can see that down below. And then in the twins group, 3,956 were frozen, 29,742 of them were from the fresh cycles. So interesting data, very important, big numbers, which gives you good, robust results. Okay, so I can't blow this up any more than about that. Hopefully people can see it. So this is a comparison of the perinatal outcomes between singleton live births with fresh or frozen. So they just took all the people that had the singletons and then they compared whether they had fresh or frozen. So ignore all the stuff in the middle because it's not really important. The meat is in that area I've highlighted with the yellow box for you guys to see. And I'll go through it one by one with you. So very preterm birth versus full-term birth, there was a 17% decrease when you had a frozen embryo transfer. So this is very, very important. Huge decrease in having extreme premature infants. Preterm versus full term, 7% decrease when you had a frozen embryo transfer. Low birth weight versus normal birth weight, a 28% decrease in having low birth weight babies. Excuse me. And then when they excluded the preterm babies, so you were actually just looking at term babies, you could see that they had a 38% decrease in the low birth weight still. But then when they looked at high birth weights, there's a huge increase in babies that are chunkier when they're born from a frozen embryo transfer compared to a fresh embryo transfer. So the frozen embryo transfer babies are coming out heavier, and the fresh embryo transfer babies are coming out smaller and more premature. So this is very, very important data to remember. Birth weight adjusted for gestational age, small for gestational age was 34% higher with the frozen. Large for gestational age was 62% higher with the frozen. Congenital anomalies were less in the group that was frozen, and healthy babies were less, which is very strange, in the group that was frozen. So I can't really understand that, but when I went and I looked at it, they said that it was primarily because the babies were heavier at birth, and they considered that not to be healthy. But heavy babies at birth are healthy babies unless they have sugar problems. Later in life, if they're very heavy at birth, you do experience higher risks of high blood pressure, diabetes, cardiovascular disease. But early in life, these are going to be healthier children for sure than preterm babies or those who are very small for gestational age. And small for gestational age also carries increased risks of high blood pressure and diabetes later in life as well. Okay, so the second thing they looked at was this one, and this one's going to be hard to read, so I apologize. But essentially, they looked at the outcomes between twin live births, fresh and frozen. So what about if you're putting in 2 embryos at a time, or you're ending up with twin gestations? So kind of the same findings, essentially. Gestational age at birth, very preterm, 16% lower with frozen. When they looked at the risk of preterm birth, not very preterm, it crossed the 1 point. So it actually was no different. You want me to try going that way? Is that better? Yep. So there is no significant difference, and that's the one you can see right here as I highlighted there. Low birth weight versus normal birth weight, 28% reduction in low birth weight babies when you had a frozen. High birth weight in this group actually was lower. So there was a 48% decrease in frozen versus fresh in the twins group. Hard to figure out why, but that was there. When they excluded things, you got basically the same results. The low birth weight was still very significantly reduced. The high birth weight was less reduced, but still reduced. Congenital anomalies, no difference. That's right down here. You can see that right there. And healthy baby, they actually showed an increase in healthy babies in the twins. So there is some discrepancy between what they're seeing when you have 2 babies versus 1. Oops. On to the next page. Do you want me to blow it up like that? Is that better? Okay. So this one was with the siblings, looking at whether or not a fresh initial and then a frozen second, because obviously it would be frozen second, had a difference. So in the frozen group compared to the fresh, there was a huge decrease in very preterm births, so 44% decrease. And in preterm birth, a 19% decrease. Low birth weight babies, again, 44% decrease, but a huge increase, 85% chance that you were going to have a high birth weight baby if you had a frozen embryo transfer compared to a fresh embryo transfer. So big decrease in the preterms and the low birth weight babies, but a huge increase in this large for gestational age component. They then looked at the same things they've looked at before with excluding the preterm babies and then looking for the low birth weight and high birth weight. It was non-significant for, whoops, let me highlight that. Oh, it won't do it. Hang on a second, guys. Sorry. Let's see if that works. Yeah. So here you can see where I highlighted it that low birth weight was not significant. High birth weight, however, 92% increased in the babies that were not preterm and were born, at a normal time. They're coming and they're quite large. In terms of congenital anomalies, there was no difference. And in terms of healthy babies, there was also no difference because the confidence interval crossed one. So in all of these circumstances, the important thing to recognize is essentially you're seeing less small for gestational age children. You're looking at less preterm babies. You're looking at less very preterm babies, but you are getting an increase in these heavier babies. People out there? Yeah, there are. I may have to ask you to go chat with them. So bottom line with all of this is that you have a much better chance of avoiding significant complications if you aim for a frozen embryo transfer than fresh. Now, the interesting part with this article is that the authors say that it's actually better to go with the fresh because they felt that these bigger babies were unhealthy. But that's actually maniacal, because what they were not looking at was the NICU outcomes and the birth outcomes afterwards. And those outcomes are significantly going to be compromised if you're having preterm babies or very preterm babies. So that is super important for everyone to recognize, because those complications are huge and they're not accounting for that in this study. So when they call it a healthy baby, they were just looking at birth weight and they're saying heavy is worse than light, but that's actually not the case at all. So something very, very important for everyone to recognize. So is it a fact or a fiction that doing a frozen is safer than a fresh? It's actually a fact that doing frozen is going to reduce significant complications, and it should be addressed. A fresh embryo transfer will increase your chances of prematurity, low for gestational age babies, and that's a very significant problem. So hopefully you enjoyed that, and maybe it'll guide your decision making and that of your clinic. Don't hesitate to give us some feedback if you have questions, and make sure you like and comment and subscribe on YouTube and follow on Instagram. So we're going to take questions right after Tarek goes and yells at those people outside.
I'll give you something for now.
Give me some meat to deal with.
Yeah. Hi, Dr. V and T. Why do stimulation meds cause increased TSH levels?
Oh, that's complicated. So
I can leave on that one?
Yeah, and I'll look if I have to.
Okay.
Yeah. So stimulation medications drive up your estrogen, and your estrogen can alter multiple different hormones in your body. One of them that gets impacted frequently is your TSH, and people that have TSH problems are or even are sensitive to TSH issues can have significant alterations in their TSH. Some of it may have to do with sex hormone binding globulin. A lot of it probably just has to do with the estrogen level going up. It does definitely pose a problem for some people. And if you have thyroid issues, it is quite critical to be very observant of your thyroid levels through your cycle, even during the embryo transfer preparation process. Now, it's not as much of an issue if you're doing stim, as long as your thyroid isn't wildly fluctuating. But during embryo transfer, it is very, very critical. We don't tend to see problems with the thyroid swinging quite as much during FET prep, but that's also because we're not using estrogen. We use a letrozole-based protocol. And because we're using a letrozole-based protocol, we don't seem to have quite as much trouble as they do the rest of the time. Did you tell them to don't sit on your phone? You tell them to leave, or did you tell them to?
I got confused when I got out there. There's an older lady and 2 kids. I was really confused.
Really?
What to say?
Okay.
I went out assuming they're teenagers and hooligans,
and they were older.
And then I see a mom and her teenage sons, and I was just like, "We're trying to do something. Do you mind keep it?"
That's so funny.
They don't know what to do with it.
We have a courtyard outside our office because it's very lovely, and I guess it's become a hangout place at 8:20 at night.
I don't know what's going on. Maybe they're reminiscing. You were born here. We took you here when you were young. I don't know. Anyway, you did that one?
Done. I just
Okay.
finished.
Okay, great.
I timed it perfectly for your return, buddy.
You're always incredible. I froze 55 eggs between the ages of 36 and 37.
Woo! Wow.
I
Okay.
hear so many stories of egg freezing not working.
Uh-huh.
Do you think I will have any babies from the frozen eggs?
So the average at 35 is that you need 15 eggs to achieve one live birth. That's from a study from Spain. So, I mean, you should have enough for almost 4 babies. Maybe not a full 4, but I would say 2 to 3 for sure. So if you have that many eggs, you probably did very, very well. I wouldn't think you need any more. We would never even tell anyone to gather that many unless they were much, much older.
Hi, Dr. V&T.
That's us.
Yep, that is us. I believe me, I noticed the letter. I just did a timed intercourse cycle with letrozole and trigger. I had a little bit of brown spotting with cramping at 6 DPO. Cramping and other pregnancy symptoms are ongoing, and she continues.
Okay.
13 DPO had a little bit of pink spotting and then stopped.
Okay.
14 DPO, no period and negative on urine pregnancy test. Is pregnancy still a possibility? Thanks for your thoughts.
Well, a urine pregnancy test is not that accurate, so we would never use a urine pregnancy test to tell you yes or no for your pregnancy. They're very reasonably accurate, but it's not as good as doing a serum test. So is there a possibility? Yes. Is it a high possibility? Probably no, but it's a reasonable possibility for sure. Yeah, so make sure you get a serum test and not just a qualitative, which is the urinary test.
Hi, Dr. V&T. If you only prime with DHEA,
Yeah.
do you have to start stim meds earlier to prevent lead follicle or lead follicle?
A lead follicle?
Lead follicle?
No, we prime at the normal time. Usually for people with weaker ovaries, we might start on day 2 because we do find they're a little more out of sync and they'll be starting their cycle earlier, often because your FSH is higher. So it's kind of pushing the follicles earlier than it's supposed to. But no, we would start on day 2, which is normal for us. Yeah, but not any earlier than that.
On Instagram.
On Instagram. Do you want a drum roll?
Yeah, I'll take it.
We need like an electronic. We should get a synthesizer. I can get some.
You know what? That's not bad. That adds some spunk to it all.
It would add some spunk.
You need a green couch and a synthesizer.
We talked about the green couch.
It'll be quite the show.
Yeah, in the new office. Yeah.
Hello! Exclamation mark.
Oh, okay.
That's why I helloed it like that. When is the best time to start ending taking NFH, Flora, SAP probiotics before an NFT, before an FET? Thank you.
I would stay on it until you're at least a couple of weeks pregnant. I wouldn't stop. Yeah, just stay on it the whole time. It's good stuff to have. We definitely continue it through the FET, but you can even stay on it longer than that just to make sure the pregnancy is established before the bacteria gets disrupted.
Hi, Dr. Victory. It's my first live here with you.
Oh, great. Welcome. Hope you're enjoying the show.
You know, I actually like that comment a lot. It's my first live with you. It's good. It's good.
Yeah.
Hi to my favorite TV team.
There you go.
That's got to be comment of the day for sure.
Very cool.
Let's see someone top that. Evidence behind Decadron in a ER protocol.
In an egg. Decadron. I mean, there's evidence for dexamethasone. I'm not familiar with anything specifically for Decadron, but dexamethasone has proof. We've reviewed it before. Actually, I've got a whole folder on it sitting here on my computer. There are lots of studies that show that in the right circumstances, it can improve your outcomes. So I am a believer in using Dex for specific categories of patients. It's not useful for everybody, but it can be useful in certain situations. So I would support it in those situations for sure. We've got a whole file. I'll read some of these off to you. Low dose dexamethasone on patients with early follicular phase progesterone level and pregnancy outcomes. So they said progesterone secretion can be suppressed by Dex, and it may sensitize the ovaries to gonadotropin stimulation in IVF treatments. The cumulative live birth rate was higher in the DEX group than in the controls. And the obstetric and neonatal outcomes support the safety of DEX. So that was one study. And then the next study, actually, I think the next one was very similar. Yeah. Then the next one, low dose DEX augments response. So they showed that you got an improvement. So the summary, the conclusion, low dose dexamethasone co-treatment reduces the incidence of poor ovarian response. So you can improve your ovarian responsiveness by using low dose DEX. And that was pretty much it. There are other studies too, but those were the ones we had reviewed. So I'm a believer in DEX. We do use it from time to time, but it's not for everybody.
Lupron versus Lupron Depot for endosuppression. Does it matter?
It doesn't matter, but Lupron Depot is one jab and you're good for 3 months. Lupron is like jab, jab, jab every day, right? So why would you do that when it's got the exact same outcome? And I guess in theory, if you're taking Lupron daily, it's going to go up and down. So you're going to get that waxing and waning effect until it stabilizes, and then you're kind of hoping it stays stable. But Lupron Depot, it just like overwhelms your system and it's there the whole time. So it's going to give you a stronger effect theoretically and pharmacokinetically than the daily Lupron will.
Aspirin, embryo glue. My clinic doesn't do that.
Tell your clinic to get with it. I don't know what to say. Aspirin is incontrovertible. Anybody that's arguing the benefits of aspirin just simply does not know the data as far as I'm concerned. Embryo glue is more controversial, but we did review embryo glue, and we have a video on embryo glue, and there is a meta-analysis that shows that it's beneficial. So we actually have just included it in all our patients now. A lot of places are charging a lot for it, several $100s, like $500, $600. We stopped after the study came out saying that it's beneficial. We used to charge for it as well, but we blended it into our overall costs now because of the fact that the study said it, basically everybody's benefiting from it. So we just said, well, we can't, charge people for something that is benefiting everybody. So we blended it into our cost. By the way, our costs are going up very soon because everything that we purchased to do your cycles for you has gone up on average about 20%. So probably by next week, our costs will rise as well. Sorry, but it's inflation and I have no control over this one. So we will be charging more. So if you want to secure IVF this week and next week are probably the times to do it. And then after that, we will have a price increase probably early to mid-September. Sorry, guys. Yeah.
Happy Tuesday, Dr. V&T.
Excellent.
Can you discuss the research on day 7 embryos? Is there any info on the health of infants born 36 years old SMBC?
Single mother by choice.
There you go.
There you go. Where is that study? We have a video on that. Day 7 embryos have only about a 15% chance of implantation. And they are definitely lower in the percentage that are genetically normal. There was one study which suggested that a day 7 genetically normal embryo has the same implantation potential as a day 6 and a day 5. But personally, I think that's completely false. There's no way that that's possible. An embryo that's taking that long to develop, even if it's genetically normal, does not have the structural and energy related machinery to help it continue to develop. And that's why the initial study said it was 15%. I wish I knew where that study is in my list, but we do have it. And it is not great. If you have day 7 embryos, I would encourage you to use them, but I would be prepared to be doing another cycle because it may not work.
Dr. Victory, thank you for your compassionate and direct manner.
Thank you.
Should ovulation be on the same day? Why might it not? And should anything be investigated?
I'm not sure I understand that question. Thank you for the compliment, but I don't know what you mean by on the same day. Did she have a pre or he have a pre question?
This is the same person that just had the SMBC. This is the same SMBC, single mother
Yeah.
by choice, doing IUIs. That's all I got.
Your ovulation and your IUI can be the same day if that's what you're asking, or it can be at the 24-hour mark post trigger or surge. So if you're naturally surging, your IUI should be 24 hours later. If you are injectable surging, like in other words, you're triggering the ovulation with HCG or double trigger or whatever you're using, then you should be doing it either 24 or 36. They've compared 24, 36, and 48. There's no difference between 24 and 36, but 48 has lower chances. So don't do 48, but 24 and 36 are the same. So you should be doing it either the day before you're ovulating or the night before you're ovulating or the same time that you're ovulating, roughly.
Hi, Dr. VNT. I just did a timed intercourse cycle with letrozole and trigger.
Okay.
I had a little bit, did this one. Hi, Dr. VNT. You know, when it sounds good, right? If you only prime with DHEA, do you have to start stim?
No, you asked that one too.
Oh, okay. AFC equals 6. 20 units LDLCG.
HCG.
Yeah. 200 follows stim.
Yeah.
10 milligrams letrozole.
Yeah.
Would you recommend dual trigger for this protocol? Does utilizing a Lupron trigger have a negative effect for a fresh 3-day transfer?
Not if you mix it with HCG. If you've got 6 follicles, I'd probably recommend against a fresh transfer because your estrogen level is probably high enough to muck it up, and make sure they measure your progesterone levels. With regards to the low dose HCG, I absolutely do not support that protocol at all. It doesn't make sense, and it's never been shown to be beneficial. So that's not something that's sensible to me. 200 of Follistim is fine. If you want some HCG effect, you should be using Menopur. I think that about sums all of that up.
I concur with the Menopur.
You concur, yeah. Tarek likes Menopur too.
Yeah. Hi, Dr. V. And Magnanimous Tea. Oh, wow. Wow. If there was a button to like on this, let me tell you. Magnanimous Tea.
Wow. He's blushing. You can't see him, but he's totally blushing here.
The Rouge.
I know. It's great.
It's good.
It's good? It's good. You're so happy.
What is your experience? I'm even confused who the question's to at this
there
point.
You go. Yeah. Maybe they're asking you.
Yeah, they might be. With the benefits of adding HGH. In my experience, I don't know personally.
That one you're not sure?
Yeah. But I'll give it to you, but she adds on a little bit more.
Yeah, okay.
I've had issues of embryos mostly growing slowly and arresting at morula or pre-blast stage.
Okay.
Could it help?
Yep. So it's being shown to increase the number of eggs. It's being shown to increase the number of mature eggs. It's being shown to increase the number of good blastocysts. The only thing they're not sure about yet is whether or not it actually can increase live birth. That is questionable. We're still not seeing that. But overall, yes, it is pretty useful for a variety of different things. There was a meta-analysis we reviewed. Gosh, when was that? I don't know.
I'm still on Magnanimous.
You're still on Magnanimous?
Yeah.
I can probably share this with everybody. Let's do it that way. How about that? Hang on one second.
Oh, hold on a second.
Well, I got to send it to us anyway. So let me go
If you just have it on your window, I can.
Well, I got to send it.
Yeah. Okay.
Yeah, hang on one sec. I got to share it to this thing and then open it. So it's on my desktop instead of the laptop.
Mm-hmm.
Okay, here we go, folks. Accept my books. Are we sharing? Or do I need to share?
You haven't shared yet. You need to reshare.
Okay, I will reshare in a minute. Here we go. Okay, so this is a great question you've asked, and I'll share with you an article that we did review on our show. I think it was last year. It's right here. Growth hormone co-treatment for poor responders undergoing IVF. So they looked at 12 different RCTs, randomized controlled trials. Altogether, there were 586 women in the control group, or sorry, in the treatment group, 553 in the control. So you did get an increased live birth rate in this population. It's not for everybody, but they did. You got decreased miscarriage rate, it did not show an increased live birth rate, miscarriage rate, or ongoing pregnancy rate. However, in these poor responders, they got higher number of eggs. They got a higher clinical pregnancy rate, more mature eggs, and more embryos to transfer. So it's equivocal as to whether or not this stuff works. And this is a very small subpopulation of patients, but we do use it now. If you're in the US, it's complicated because it's so bloody expensive there. If you're in Canada, using Omnitrope, it's literally 50% of the cost of what it is in the US. So Tarek and I are actually going to be working on a video that he doesn't know about yet to compare the differences between doing IVF in Canada and the US. And one part of it will be our pharmacy team coming on to talk to you about the drug costs. So we will have that as part of our video to go through things.
You vanished.
I vanished?
Yeah.
Like I'm off camera?
You're off camera.
Because we're toast for battery life?
I think I left the camera
on. Your share's still being screened.
Okay.
So
but I've disappeared.
But yeah.
Can they hear me? Oh, maybe not.
No, probably not. Unfortunately. Hold on, we'll bring you back.
I'll post to people. Oops.
Okay, you're coming back right now. Don't worry.
All right.
I'll close your door since we have that 2 seconds.
Oops.
Okay. You're back.
I'm not working. Am I?
Yeah.
Okay, perfect. Sorry, we drifted there for a second. So, yeah, we will have a video on the comparison between Canadian and American.
Oh,
they
no,
could?
how?
Oh, wow. All right, we are back. All right, so what's the next question?
So I asked a question on YouTube to our followers here.
Okay.
And
you asked the question?
Yeah. I asked them a question. You know, they're always asking us. I figured it'd be nice if we asked them a question.
If we asked them a question?
Yeah. I figured, what the heck?
That's different.
Yeah, it is different. And the question itself is also quite different. I asked them, do they enjoy, the conversation or the banter? Yeah, okay, between us two. Right? Yeah. So for the Instagram people, and for Facebook, they can, on YouTube, you can actually vote.
Okay.
So out of 7 votes so far.
7?
7 so far. And I asked that literally as that thing just clocked out.
Yeah.
7 say, 8 say unanimously
that they like it.
They enjoy it.
It's quite the dialogue.
YouTube has been silent so far. I think they're a little bit more shy.
Okay, we'll find out.
We'll find out soon enough if YouTube likes us.
Yeah.
Okay. I'm sure they love you. No debate about that.
I think they love you just as much as they love me. It's group love.
Group love.
Yeah.
Okay. Again, here you go.
Stop sharing.
Yeah, no problem.
Okay.
It's all you, boss. Oh, I'm almost in the camera. Whoa, sneaky. My mug is here. That angle is quite the mug.
It's quite the mug.
So remember, you're looking here now.
Oh, I'm looking there now.
You're looking there
you
now.
You didn't tell me that.
Yeah, heads up.
Well, let me move this in front here.
That's much better.
Is that better?
Well, at least I can sit comfortably.
Oh, there you go.
Wasn't ready for the camera today. Would have done my hair.
Fire away.
Hi, Dr. VNT. I just transferred yesterday and modified natural.
Okay.
But my estrogen was 0.78. So but estrogen 2 milligrams twice a day.
My estrogen was 0.78 or my progesterone?
My estrogen.
Okay.
Was 0.78.
Okay.
So but estrogen 2 milligrams twice a day.
Yeah.
This will affect transfer. Thank you. And very excited.
No.
My 3AA expand to hatching.
No, don't worry about it. No one really even pays attention to estrogen levels at transfer time, so it's not important at all. You're fine.
Hello, Dr. VNT. What is your thoughts on spindle view and embryo scope kid score? Would you recommend for Ford to go cycle?
No. So the KID score, we have the KID score on our system. We don't use it. It's useless. It was proven to be useless in a randomized controlled trial. So far, the artificial intelligence schemes that we have not been proven to be useful for anyone. So don't bother trying to use that. The spindle score, it's like totally useless. So ignore that too. There's no data that support that. So we don't use it.
There's some funny comments. I'll go to the questions. I don't want to waste.
No, tell the funny comments. I'm sure people like that.
So they said that
we got 16,000 views for that raw liver thing. And all I did was go, no.
You know what threw me off the most?
16,000 people.
Something really threw me off with that raw liver video.
Yeah.
The amount of crunchiness that was happening.
I noticed that too.
It was too much for me.
It was disgusting.
Yeah.
And, and who walks around with a slab? Like, where do you go where you just walk around with a slab?
She killed the animal that minute. She gutted it and just pulled it out and chewed it. That's the only explanation for that.
Crazy. By the way, I have a whole slew of fresh fodder for other Nope videos, but we're going to release them like once a week. So hopefully you guys enjoyed that one. We will be doing another one very soon.
Batman and Robin, you need to cue the battery signal.
Oh, that was because we fell.
I didn't like that one.
Wait. Which one of us is
Let's not get into these details, all right? Let's not get into these details.
All right.
You know what the problem with Batman and Robin? Fundamentally, there's a problem with Batman and Robin.
Okay.
Everybody loves Batman.
Yeah.
And everyone acknowledges that Robin is the sidekick.
Right.
But I don't know if anyone actually likes Robin.
I like Robin.
Oh, there you go.
I like Robin. I was like the underdog.
I think it's because some of my kids watch there's like a Teen Titans show.
Oh.
And Robin's really obnoxious. He's not really the action fighter.
Okay.
He's just a loser. So that's my last recollection of Robin. So no one answer who's Robin or Batman. We're both Batman. But we just know there needs to be a Robin. I'll go with that.
Yeah, okay. We're both Batman.
Yeah.
The show is going off the rails, man. Okay.
Here,
thanks.
serious question.
Serious. All right.
Last hybrid IUI, ultrasound scheduled for Thursday. Follicles should mathematically size at 17 to 18. The reason I'm laughing is because just now on Instagram, you just caught your there's a bit of a lag.
Okay.
So do you suggest Gainer Relax shot prior to trigger since my clinic isn't open Sunday?
Ooh. If you have a 17, she said 17?
Yeah, 17 to 18 millimeter.
Yeah, you could trigger on your own. So if you have to wait, then yeah, you're going to need Ganirelix. But the right trigger time is like around 18, 19, 20. So I wouldn't be doing that for too long. Like your clinic may need to accommodate a sooner time for you. Yeah.
Does your clinic allow new patients to move embryos from another clinic? They are untested embryos.
Yes, it depends though, who they're going into and what quality they were and who made them and your age and stuff like that. So, for example, we have patients sending us embryos every day from all across the world, a lot from Australia for some reason. So when we get patients that are sending us embryos from the States or Australia, if you're, for example, 43 and your embryos were not tested and they're day 3 embryos, no, there's no point in sending those because we have very little faith those will work. And so that's not prudent. But if you're young or younger, or you have very robust, healthy embryos, we would totally be on board with having them transferred to us as long as it's reasonable. So we make individual judgments on a case-by-case basis, and I would be happy to have you DM me and just say, hey, these are the quality, this is my age, this is my story. Will you take the embryos? And we'll discuss it and figure it out together.
Do you have any idea or thoughts on why frozen transfer results is higher birth weights?
So I do. The theory is that the high estrogen levels with a fresh transfer result in inflammation and spasm of the blood vessels in the uterus, which compromises the development of the placenta, which then feeds the baby less blood and oxygen and sets the baby up for being smaller. You don't get that with a frozen embryo transfer because you have more normal development. And why are those babies bigger? Probably because we were so careful with those pregnancies and with the management and all the supplements and the nutrition. Everybody's being so careful that they probably, get bigger babies. They're larger babies because they're being overfed and overnourished and overprotected.
What IVF protocol do you suggest for a 31-year-old woman with low egg reserve and stage 4 endo?
Oh.
I had excision surgery on December 2019, one successful FED with 3-month Lupron plus letrozole,
Yes.
followed by protocols with aspirin, esterase, and progesterone suppositories. Have had 2 more FETs since with the same protocol that failed to implant at all.
Okay.
What IVF and FRT protocol would you recommend?
Okay, so IVF protocol, it would depend on how weak your ovaries are. There are things we've reviewed on the show which will help. So from a medication standpoint, Vizan for 3 months has been shown to be beneficial in endo patients. Actually, nothing else has. We do use a lot of supplements, NAC, curcumin, resveratrol, coenzyme Q10. All 4 have been shown to have some benefit in endo patients. So that's reasonable as well. We would probably recommend a letrozole protocol with stimulation, whether you're doing antagonist or microdose flare, that's up to you. I believe in the microdose flare, so that's probably what we would use. You may need DHEA, that would be useful as well to try and kind of boost the strength of the ovaries, plus minus testosterone priming if you prefer kind of a shorter prime. Once you're getting to the FET, that one's easy. Lupron and letrozole for 3 months, all of the supplements, try and avoid any estrogen exposure if possible.
Hello, Dr. V&T. In cases of unexplained infertility, how reliable is Fertility testing? What other testing would you recommend? Very nervous to try IVF without having any answers.
So we know that with unexplained fertility, there are only 4 things that actually work. Fertility is not one of them. I believe in fertility because it's useful, but we never recommend fertility for unexplained infertility. We recommend it for patients that have failed IVF. In certain other circumstances like recurrent second trimester miscarriages or signs that there's an infection or an immune problem. But in general, there's only 4 things that work, and we repeat this over and over again. We've got posts on it on Instagram. We've got videos on it. I have a great video called Unexplained Infertility on YouTube, where it's a play-by-play that I gave at a talk at the Toronto Fertility Show last year. So you definitely want to watch that if you want to learn about unexplained infertility. The only 4 things that work are IUI with pills, not just IUI and not just pills. It has to be the IUI with the pills, so letrozole or Clomid, and they're both the same. IUI with shots or a combination of pills and shots, IVF, and surgery. Those are the only 4 things. So if you have true unexplained infertility, they've explored everything about you and your partner, not just the basic testing, but the full testing, DNA frag, you've eliminated smoking, drinking, drug use, your vitamin levels are checked, your stress levels are low, you've tested everything that can be tested and there's still no answers, then surgery is a very realistic option, or try some of the more basic stuff before you jump into IVF, like insemination with pills. If that still doesn't work, then it's a discussion of should you do IVF and a discussion of should you engage in surgery to see if you have endo or have something else. I just posted on this yesterday. 20 to 25% of completely asymptomatic people will have endometriosis, or 20 to 25% of people with endo will be asymptomatic, I should say. So you could have endo and not know it. And that's something really important because it cuts your chances of pregnancy down hugely. So that's very, very important for you to check.
Hi, T. Hi, Dr. V. My doc isn't paying enough attention to my lining issues.
Oh, sorry.
I only have 2 euploid embryos. Might change REs. Would love to work with you, but I'm in CT. Do you know any REs in NYC?
She's in Connecticut?
That's what I'm thinking.
Must be Connecticut.
Yeah, Connecticut for sure.
Yeah. The only, well, I think he moved. Yeah, I don't know anyone specifically in NYC that I trust. In fact, I'm constantly on the phone or on Instagram with one of my clients who did a cycle recently in NYC and was not at all happy with the results, and I don't blame her. It was a not ideally managed cycle, to be sure. So I don't know anyone there. Coming from Connecticut to us is easy, so you could ship your embryos here and just get monitored there and show up here for the transfer, and then we would be running everything for you. We do have a lot of US patients, so that's perfectly fine. If I was going to NYC, Eric Foreman is the only one that I would probably trust, and I think he's heading up Columbia. He is extremely, extremely bright, exceptionally gifted individual, very, very intellectual. So that's the only person I know of in NYC that I would have any faith in. So that's Eric Foreman, and I believe he's the medical director at Columbia University's IVF program. He trained at RMA and was very well regarded by Richard Scott, who is a genius in the IVF world. So I think you could not go wrong, speaking to Eric. He's great.
Hello, Dr. VNT.
Hello.
What is your thought? Oh, we did this. Hi, Dr. V. I just yep. They're making it hard. Hi, Dr. VNT. Does allopurinol to lower uric acid levels affect sperm quality to fertilize and influence IUI success rates?
Yeah, I've looked this up. There is some data that it does. So for people that have gout who are on allopurinol, it can impact your sperm quality. Now, for God's sakes, don't go off of allopurinol because gout attacks are horrible. So those are situations where you may need additional help. And you can eat really clean to avoid gout. So maybe you could trade off your allopurinol if you're avoiding all the triggers, but it's not an easy thing to do. So, and for those of you that suffer from gout, my heart goes out to you. It's awful. My dad has it, so I get it.
Can long-term use of DHEA cause increased TSH levels since testosterone is converted to estrogen?
I've never looked that up before. I guess theoretically it's possible, but I don't know. I will look it up while Tarek challenges me with yet another question.
You might need to focus. Some numbers are going to come at you.
Okay.
Is TSH? Yeah, I know. That's why I said might need to focus.
All right.
Is TSH 1.5 ULU over milliliters to microliters, right? Nano? UI.
Microliters.
Microliters, yeah.
Yeah.
Microliters to milliliters over milliliters. ULU over ml.
Micro international units per milliliter.
Micro international units per milliliter.
Okay.
There you go. Got to make sure that's clear.
Yeah.
Is TSH of 1.5 what?
Micro international units per milliliter.
There you go. To 2.9 after stimulation cycle normal. If not, how would you deal with these huge swings? Is this possible cause for failed IUI with trigger? And then she follows up with Ken Long. Oh yeah, that's it.
That certainly would not cause a failure in trigger. It's borderline normal, acceptable levels. So I wouldn't be worried about that at all. To me, that's not making any difference at all. So I wouldn't worry about that. I'm not finding anything on DHEA. DHEA supplementation and TSH levels.
Would you transfer 2 6-day embryos 3BA versus a day 5 3BB?
Oh, good question.
That's a good one, eh?
2 day 6 3BA versus day 5 3BB.
Mm-hmm.
No, I do the day 5.
Day 5 no matter what, eh?
Yeah, it's probably stronger.
Seems like a consistent day 5 is number one no matter what. Unless it's like AAs.
Yeah, AA is a different story.
Yeah.
DHEA, I can't find anything on PubMed, guys. I mean, I'd have to search because there's probably 1,000 articles, but in the first few, I see nothing. I'll keep looking, but go ahead.
So, hi, Dr. V, and hi, T.
There you go.
Hello. We may have endometriosis.
Okay.
We were wondering how it can be managed, and if it is, what is the success rates of pregnancy with IVF afterwards? Thank you.
It can be managed medically or surgically and naturally, but naturally isn't going to quell endo, so you do need some medication or surgery. So surgery is laparoscopy. You can remove it, you can burn it, you can treat it. And some people believe in evaporating it with special lasers. Doing it medically would be Vizan, high-dose progesterone. Birth control suppression will kind of calm it, but it doesn't get rid of it. You can use Elagolix, which is also known as Orilissa. You can use a GnRH agonist, and that's very strong and works quite well. So any of those things will be reasonable. And then in terms of success rates, you can almost normalize your success rates with IVF if you use the right protocol. If you use the wrong protocol, it's a disaster. But if you're using the right protocol, there is a good reason to expect that you will do very well. Those are in cases with mild, sometimes even moderate endo. If you've got severe endo, it is difficult. There's no question. And there are some people that will have a very rough time. So it depends on the severity of your endo.
I have one fresh transfer that ended in early miscarriage.
Oh, I'm sorry.
3 subsequent frozen transfers have failed to implant.
Oh.
Any idea why my body is less receptive to frozen embryos?
I doubt that it is. I would need to know more about you. Most likely your clinic's using the conventional protocol and pounding you full of estrogen, and that's a terrible protocol. And then there are all these other things, your vitamin levels, your thyroid levels, your supplements, your weight, your husband's sperm quality or your partner's sperm quality. All of these things factor in. Smoking, drinking, drug use, endo, do you have endo? Is your bacterial content normal? Like there's a million different things that go into it, guys. So I can't tell you kind of off the hop what it would be, but there are many different possibilities. Contact us. I'll go through it with you in a consult. Then I can tell you. And that's not because I need you to, pay. It's because I can't answer without having like an hour to learn everything about you.
Do you recommend estradiol orally or vaginally?
We use it vaginally because we don't use it. And so when we need it quick. And it's much faster giving it vaginal. But in a perfect world, I would use it either transdermal, which is the best way, or oral, which is arguably second best. But vaginal, you get a really high spike in the level initially, and then it kind of quickly dwindles down. But oral and transdermal is a little more like kind of controlled. And I'm toying with the idea of switching to the transdermal to see how we do.
Could DHEA fuel the fire for endo?
Not that we are aware of.
Dr. V and T, do stop NAC after transfer?
No, just stay on everything after transfer. Never mess with your meds after transfer. Stay on everything because your pregnancy does not like disruption. And pregnancies like what we call homeostasis, which is all your hormones stay like totally controlled and level and everything's good. So don't alter that for anything.
Thoughts on PRP for egg quality and before FET?
Egg quality, it's completely up in the air. Nobody knows. There's a clinic in New York with 4 locations now, I think. And I believe it's owned and operated by an Iranian gentleman who swears up and down that, what's it called? Organic IVF, I think he calls it,
yeah,
right?
Yeah.
That it's like, amazing because they're doing PRP and everybody. Yeah, it's all nonsense. There is no proof that PRP works, not a bit. The only study out there showed an 8 to 11% live birth rate in women with poor outcomes previously that got PRP. I asked the author of the study about his opinion of that, and he said it looks promising, but they don't know yet. And that's from the guy that did the study. So, there's still a lot to learn. PRP in the uterus, however, is awesome. So we do support it in the uterus for implantation problems, but not for in the ovary yet. We are considering doing it. I don't know. I'm sketchy about the whole thing, but we probably will be doing it, at least to try as a research protocol.
All 10 of my embryos were day 6, not day 5.
That's fine.
That was the next question. Is this normal?
Yeah, I mean, some people just take a little longer. Day 5 and day 6, there are studies that show that day 5 is better, and there are lots of studies to show that there's no difference in the outcome. I don't get too nervous when I'm using a day 6 embryo. We're still getting great results, so that's fine. Day 7, different story altogether, but day 5 and day 6, if you've got a 3, 4 on day 6, that's still a great embryo.
Hey, T. Hi, Dr. V. Just so we're clear here. My doc isn't paying enough attention.
I'm still hung up on the we are too bad.
Yeah. No Robin here. Trust me. If you saw the new Robin, you couldn't do it.
You know I'm going to get you like a Robin outfit.
No.
All right, fire away.
The new Robin's disappointing, I'm telling you.
I don't watch the show, but yeah. Okay. Game of Thrones, man. That's
That's where it's at.
That's a good show.
That's
Yeah.
the new dragon one, right?
Very good.
Mm.
Yeah.
Is Omnitrope also helpful for FET prep?
It can be. There are studies that have shown, especially in women that have a thin endometrium, that human growth hormone is beneficial. So yes, it can be. Yep. Depends on the case, but yeah, it can be.
Not me sprinting to get my many-per in the next room to sprint back into the mix while watching, so I don't miss a word.
That's awesome.
Yeah, that was awesome for sure.
If you need to run and grab something, you want us to just pause the show, we can talk about Batman and Robin.
There's a lot of randoms we can do.
What car we like. Yeah.
Hi, Dr. Vic.
Okay.
NT. But I figured Dr. Vic's good.
All right, that's good.
How far along do you recommend acupuncture after FET? What other things do you recommend for success? Can I do stationary bike?
Yeah, I mean, light exercise is probably a good thing. Not like Peloton, but and I got nothing against Peloton. I mean, no like intense spin classes. You can use your Peloton. Just don't do an intense spin class. Keeping yourself toned, fit, that's fine, but don't be like exercising for weight loss after you've done an FET. Acupuncture, if it calms you, you can do it for as long as you like. If it's not calming you, I wouldn't even do it to begin with. So I think you have to decide how you feel about the acupuncture. Aside from that, stay on all your vitamins, stay on all your supplements, eat healthy, clean, avoid anything bad, have sex to help de-stress, that kind of thing. It's all helpful.
My family doc referred us to a fertility specialist at our local hospital,
okay,
and they aren't open to any changes to the standard protocol. Is this normal? Because they aren't private.
Is it normal? Yes, because there's kind of two flavors of fertility specialists, those who just keep doing the same thing over and over again, and those who really know the data and the science and are willing to think outside the box. So unfortunately, it sounds like you've just got one of the ones that won't do anything else other than what they know. I don't believe in that approach, so my advice would be go somewhere else.
I'm actually surprised that's the thing.
It's a huge thing. You know where it's really huge? In the UK.
Really?
Refuse to even listen. They won't even listen to the patients. At least here you can say, Doc, I'm thinking, and they'll listen and go, no. But in the UK, they're like, no. You don't talk to us. We just tell you what to do. It's horrible. That's why we're trying to open an office there. It's insane. It's so bad. It's terrible.
905. Last question.
Tarek's terminal question.
Oh,
TTQ.
the pressure.
You got to get a sign that comes up.
That's a great idea.
TTQ.
Yeah, you know what? I like that.
Yeah.
Okay.
With some music and,
Music. Yep.
live.
I got you.
Don't forget the music.
Don't forget the music.
Yeah.
I'm 42.
Okay.
And my AFC was 10 on day 1.
Okay.
but only one follicle after 7 days of stim. So IVS was converted to IUI.
Right.
Can I expect a better response next cycle?
I need to know more about you. I need to know if you were suppressed. Were you on birth control pill? Was the dose right? Were you stressed for some reason? What's your BMI? There's a lot that goes into that. Were you on the right protocol? So there's many different factors there that we need to consider. So I would just say, get in touch with me. We can go from there.
I think that was good.
That was a good show. Let us know how you felt about the show. There was a lot of frivolity in that one for sure. On behalf of Batman and Batman.
Yeah, Batman.
I want to say good night.
I'd rather be the Joker than Robin, if I can be quite honest.
So have a good night, guys. We will see you next week, I think, on Fertility Factor Fiction, and I will post another topic on the Friday. And make sure you subscribe and like on our YouTube channel, and on Instagram follow, and do us a favor and help us make our posts go viral, because the one with the liver eating definitely went viral, but I guess you need more to get noticed by Instagram, so hopefully you'll enjoy the other ones too. Have a good night, guys. Take care, and thanks for watching Fertility Factor Fiction.